Hi everyone, my name is Jadene Lewis. As Matthew mentioned, I'm an early career health data scientist at the British Heart Foundation Data Science Centre. Today I'll be talking about heart failure research and why the way we define heart failure matters when using heart health data. So although this sounds quite technical, these choices affect who is included within studies and what conclusions we can draw. This then has a big impact on the quality of research and ultimately on the care that people receive. So, what is heart failure exactly? So, heart failure doesn't mean that the heart has stopped. It means that the heart isn't pumping blood as effectively as it should, and people may feel tired, short of breath, and may notice swelling in their legs or ankles. It's a very common condition, and treatments are improving all the time. Understanding heart failure clearly, especially in health data, is very important if we want to improve care that patient receives and plan service as well. So in research, we often use electronic health records to study heart failure, but a really important thing to remember is that heart failure isn't always recorded in the same way. So some records of heart failure might come from general practitioners, and some from hospital admissions, and some from tests or medications. So when researchers want to use heart failure data, they'll have to decide which of these things they're using in their studies. I like to think of this as baking. So if two people have follow different recipes, they'll bake different cakes. And in the same way, if two researchers are using different definitions of heart failure, they may end up studying quite different groups of people, even though they both say they're researching heart failure. That's why definitions truly matter in research. So when we work with health data, we can't ask patients directly whether they have heart failure. So instead, we rely on what's recorded within healthcare systems. So these include things like diagnosis codes, medications, and test results, or records for hospital admissions. And the term phenotype definition is simply the rule book, which tells us how we combine that information to decide who is included in a study, which is very important for researchers. For example, one definition could include anyone with a heart failure diagnosis recorded by their GP, but others might require further evidence from tests or hospital admissions. So the challenge with with using different phenotype definitions is that different definitions don't always pick up the same people. So some definitions are quite broad. For example, definition A, as illustrated here, includes diagnoses, recordings, and prescriptions. These sort of broad definitions will extract a lot of patients, some of whom might only have limited evidence of heart failure. However, some other definitions, for example, definition B, as shown here, which further requires evidence from a test, where these sort of more specific definitions will identify fewer patients, and these sorts of patients might be more severe or have more specific types of heart failure. All of these are still valid ways of defining heart failure, but they will identify different groups of people. And this therefore means that two researchers who both say they're studying heart failure might actually be studying quite different groups of patients. And this can subsequently affect how common heart failure will appear to be and how sick such patients will appear to be, and therefore how well specific treatments might appear to work. And therefore, understanding these differences in phenotype definitions is crucial if we want fair and accurate research. So when we can understand that different phenotype definitions will give us different answers, the next question is, what can we do about this? So this is where the term benchmarking comes in. And benchmarking simply means comparing different definitions side by side to see how well they perform. So in benchmarking, we will look at things like how many people each phenotype definition will identify, and whether these patients will look similar in a medical setting, and whether the definition matches what the clinicians might expect from such patients. The important point to to mention is that we're not trying to pick one single best phenotype definition for heart failure in this work, but instead the goal is to understand the strengths and limitations of each definition so researchers can choose the right definition for the question they're asking. So how do we do this work in practice? So this work is very much a collaboration between the health data scientists and clinicians within the British Heart Foundation Data Science Centre. So the clinicians would bring the expertise about heart failure in practice, and the health data scientists will bring expertise and experience working with large health data sets. We use large, secure NHS data sets, and all data is handled safely and ethically. And together, it helps ensure that the definitions we develop are meaningful in a clinical setting and reliable for research. So we identify multiple heart failure phenotype definitions and apply each definition to the same base population, and we can then compare what patients are extracted from applying each type of phenotype definition. For example, in this slide, you can see that definition A identifies the largest group of patients, definition B is smaller, and definition C is the most selective. So depending on which definition you use, heart failure can look much more common or much less common. And there isn't a single perfect definition, and each one will have its trade-offs. And this is why comparing definitions is so important and helps researchers choose exactly the right definition for their research of interest. So using what we've learned from benchmarking the different definitions, the next step is to turn this into something useful for researchers and subsequently patients as the end goal. So the aim is to clearly show how different heart failure definitions identify different patient cohorts, even when applied to the same population. So we will produce a set of clear outputs that help researchers understand these differences. We'll provide static summaries such as tables and graphs, which will make it easier to compare things like the number of patients identified by each phenotype definition and the key characteristics across definitions. This can include looking at different demographics such as the distribution of age and sex across the different patients identified from using different phenotype definitions. We will also provide interactive dashboards, which will allow researchers to explore results in further detail depending on the question they're asking. So, importantly, why does all of this work on phenotype definitions and benchmarking actually matter for patients? This is because better definitions will lead to better evidence, and better evidence will lead to better care. When we can identify and describe heart failure more accurately in data, researchers are working with a clearer picture of who actually has the condition, and this therefore means that studies become more reliable and more comparable and more meaningful. Instead of mixing together different types of patients, we can understand which treatments work for which groups. This stronger evidence will then translate directly into better care, and clinicians can make decisions based on the research that truly reflects the people that they are treating. New treatments can be tested in the right populations, and guidelines can become more precise, and patients will ultimately receive care that's more tailored, timely, and effective. Better definitions will also support better planning. They can help the NHS understand how many people are affected and what services are needed, and where resources should be directed. This means more accurate forecasting and smarter investment and services that are designed around real patient needs. So although this work might sound very technical, the aim is simple: to make sure that every decision around heart failure care is grounded in solid and trustworthy information so patients can get the best possible outcomes. Thank you very much for listening, and I'll now pass over to Laura for her presentation.
Thank you, Jadene. Can everyone see that in full screen?
Yeah.
Just the slides? Yeah,
Good.
fantastic. Okay. So since you've just heard a lovely presentation from Jadene, about what the phenotyping definitions are, I'm going to pick up from there and talk about why this type of work matters for clinical trials and how we can better use these electronic health records to support clinical trials for cardiovascular disease. So this kind of phenotyping work can help overcome two major challenges in clinical trials. Firstly, finding participants who are actually eligible for the trial, and secondly, following them up to determine if an outcome has occurred or not. So as you may have heard, recruitment to clinical trials can be very difficult for many reasons. It's hard to find large enough numbers, and that's even harder for rare diseases or underserved groups. It can be a very slow process, and also every study needs to check complex inclusion and exclusion criteria. And so traditionally, all of this requires that people would attend a screening visit in person, provide their information and undergo assessments, which is quite burdensome for participants and is also expensive and slow for the trial teams. But we already hold an enormous amount of relevant information in electronic health records. So that's the digital version of information which is created in the routine healthcare. So for example, the GP visits or the hospital admissions. And rather than asking participants to come in repeatedly, we can actually use these health records to pre-screen people who would likely be eligible for the trial, and then contact them if we think they meet the relevant criteria. But recruitment is only half of the challenge, and we also need to determine whether an outcome has occurred or not. And this is another area in which phenotyping definitions can help support trials. But firstly, I'm just going to take it back to basics for a minute to explain what an outcome actually is. So in a clinical trial, we usually want to test the impact of an intervention like a drug or a lifestyle change. And the thing which we measure to determine if there's actually been an impact, is called the outcome. So for example, if we were testing a new drug, the outcome might be whether it reduces blood pressure or whether it reduces the risk of an event like a heart attack. And traditionally, outcomes are decided through a process called adjudication. And this is where doctors or trialists would go through a patient's records, such as their hospital notes or test results, and agree whether an event like a heart attack has happened. There's also often a burden placed on the participant to come in for a study visit, again to ask questions about their health since the intervention. And whilst this is a very accurate method, it's also time-consuming, expensive, and sometimes puts burden onto participants. So instead, we could make use of the electronic health records, meaning we can capture the same outcomes directly from the NHS data, which has already been collected during routine clinical care. And this stable data-enabled approach has major advantages in that it reduces cost, avoids duplication of effort, speeds up trials, reduces the burden on participants, and it allows for passive long-term follow-up. But we also need to be confident that the outcomes from the electronic health records are as accurate as the adjudicated outcomes that a trialist or doctor would have decided. And given that the outcome is how we judge whether the intervention has actually worked, it's really crucial that the outcome is measured well. So if outcomes aren't measured in the same way across different trials, it's almost like comparing apples and oranges. But the problem is that different trials sometimes define the same outcome in a different way. And this is similar to what Jadene was discussing about heart failure and the phenotyping definitions. So this makes it really quite difficult to compare results across trials. And that's why we need to standardize our outcomes to make them consistent, comparable, and reliable across studies. And so some of the work which we are undertaking at the British Heart Foundation Data Science Centre aims to standardize cardiovascular outcomes for use in clinical trials. So rather than each study having to decide on their own definitions of the outcome, write their own code, and spend huge amounts of time cleaning, shaping, and validating the data, we are producing community agreed upon standardized definitions that identify important cardiovascular outcomes directly from the routine electronic health records. And so, as a first step in this, we had a group of experts come together, including clinicians, trialists, and data scientists, and they identified 5 priority areas where they felt that defining the outcomes would be most impactful. So these were stroke, heart attack, cardiovascular death, heart failure, and major bleeding. And then we've been working through these outcomes one by one, refining each definition through an iterative feedback from the clinicians and the trialists. Then, as a second step, we've created code which cleans and sorts the massive amounts of electronic health data. So that's the things like the hospitalization records or death records. And then we're running code which further classifies whether an event has happened or not based upon the agreed upon definitions. So, for example, this code would identify whether a stroke event has happened and whether this stroke was a first or a subsequent stroke. And so far, we've created code which identifies both heart attack and stroke in these electronic health records. And these algorithms or phenotype definitions can be picked up and used by trialists and other researchers. And then a third key part of this process is validation. So importantly, we need to know that if a clinician or trialist has identified a stroke outcome in a clinical trial, that the phenotype definition that we've produced would also identify that in the same way. And one way which we do this validation is to link the data from an already completed clinical trial with the health records of the same participants. Then we can compare the outcomes which have been identified manually by clinicians versus the outcomes identified automatically by our phenotype definition. And if our phenotype performs well, then we know that it's a reliable tool that saves time, money, and participant burden. And so far, our work for the heart attack algorithm, we validated that and shown that it performs extremely well. And then I just wanted to take a moment to briefly drive home why these electronic health records can be so useful for clinical trials. And I wanted to highlight one trial, the UK Prospective Diabetes Study, or UKPDS. And this study followed over 5,000 people who had been newly diagnosed with type 2 diabetes. The original trial was for 20 years, and it compared different strategies for controlling blood sugar. So after the main trial had ended, the researchers continued monitoring the participants manually for another 10 years. But by that point, as often happens in these sorts of trials, the participants were older, many had moved areas, and routine clinic follow-up was becoming more challenging. So to keep following people up over the long term, the participants' data was linked to their electronic health records, their NHS records, for an additional 14 years. And with this linkage, nearly all surviving participants, so that's around 98%, could be followed up through existing health records, something that would have been almost impossible through clinic visits alone. And this extended follow-up, it increased the follow-up time by 21%, allowing researchers to track the outcomes of this study for more than 40 years from the start of the trial. And critically, by having this long-term follow-up, the study discovered that the benefits of early intensive glucose control reduced outcomes such as the risk of death or heart attack. And they showed that this risk reduction was persistent for decades, which is far longer than anyone had expected. And all of this was possible because the outcomes such as heart attack and deaths were captured within these routine NHS records. And I think this is a really nice real-world example of how electronic health records can allow trials to continue learning long after the original intervention has ended, without any additional cost, burden, or loss to follow-up that otherwise would have made this so difficult. And we hope that the phenotype definitions and reusable data preparation code that we're developing at the British Heart Foundation Data Science Centre will also enable future trials to effectively and efficiently use electronic health records to detect outcomes and follow up participants. So to wrap up, the work that we do in phenotyping aims to support clinical trials by making them, firstly, more efficient, cost-effective, and less burdensome to participants. Secondly, more consistent and comparable through standardized definitions of outcomes. And thirdly, more streamlined by creating reusable, well-tested code so each new study doesn't have to reinvent the wheel or spend most of its time cleaning the data instead of analyzing it. And together, this all means that clinical trials could hopefully run a bit more smoothly, recruit more effectively, and generate clearer, more reliable evidence. Thank you all for listening. I'll hand over to Lars Murdock now.
Okay, so I'll be talking about Shield CVD, which, as you can see, hides quite a long name, Scottish Medical Imaging Dataset with evaluation of linked data for cardiovascular disease. Between us friends, let's refer to it as Shield CVD just for the time being. To give a little bit of context, we are very, very interested in cardiovascular disease, particularly because of the high burden of it around the world. So 620 million people living with cardiovascular disease and 20.5 million deaths per year. So a lot of activity in healthcare and high burdens emotionally, financially around the world. And a huge part of cardiovascular disease is the ability to actually use scans or routine medical imaging to look inside, to diagnose, to determine treatments. This is something where you'll see these scans here, X-rays, MRIs, CTs, those kind of things, lots of acronyms. I think for the time being, if you just sort of imagine your medical drama show where a doctor holds up a scan to the light to look at it properly, that kind of thing is what we're talking about here. But what we're interested in is the data that sits behind it. So I won't actually be talking about the scans themselves for this presentation. I'll be talking about the data that supports it. So what scan people had, when it occurred, what sort of things they were looking at and looking for. So there won't be many images here, and that's not what we're talking about. We're talking about the data that supports it. So if this is such an important part of the healthcare journey, such an important part of diagnosis and treatment for cardiovascular disease, why is it so often that we don't see people using this data related to imaging? And so we asked, we commissioned a sort of a workshop event with lots of cardiovascular researchers to find out what the barriers to research were, because we were very aware that this was quite a big gap. And common responses was that it was quite difficult to access the data, to find out the analysis and image annotation, linkage to other health data, and storage, among various other responses. So we looked to collaborate with those that had already done a little bit in the field. And it's not easy to find someone because of these barriers, but one of our collaborators, Jonathan Weir McCall, is a cardiologist, and he has done a study on this in English imaging data in the 2010s. And he found that there were lots and lots of medical exams, imaging investigations for a particular type of cardiovascular disease, or that could be used for a particular type of cardiovascular disease. So certainly a lot going on in the health space. And this was actually growing. So the number of scans was increasing over time, even above population growth. He was also able to look at what types of scans people were getting. So obviously there's different machinery that looks at different parts of the body or looks at it in a different way. Many of the acronyms I mentioned earlier that I'm not going to pretend to know all of, but we saw a very different story in which scans were being used more commonly and which less commonly over time. And in fact, you probably noticed, quite eye-catching is the orange line. This is CTA, a type of angiogram, and this was particularly increasing over that period of time. And so that caught Jonathan's interest, and he looked at, among hospital regions in England, which were the ones that were using it more and which less so. And then he compared that to those that were experiencing higher or lower changes in cardiovascular mortality. And you can see these different regions make up the STBs. There's about 42 of them. And if you plot that on a line, on a graph, you see that there is this inverse relationship. The ones that are using this type of scan more or adopting it faster seems to coincide with a drop in cardiovascular mortality. However, if you look at other types of scan or maybe other types of mortality, that's not necessarily the case. And one of the difficult things to tease out in this is it looks like there's this pattern, but that famous phrase of correlation is not necessarily causation. That's about as far as we can get with this type of research, because we can look at it at a hospital level, but we can't really dive in and see what's happening for individual patients. And as you can imagine, there might be a lot of other explanations for this. So where we might want to take this finding and spend a lot of money doing more of those kind of scans, making sure that they're more used in investigations, it's not really something we can do on the strength of this evidence alone, because, for example, it might be a case that richer areas also have healthier patients. So the places that are more able to afford to offer these scans are also the ones that have the healthier patients who tend not to die from particular kinds of mortality associated. So this is where we talk about the data, and particularly that phrase linkage to electronic health records that you heard from Laura. If we can look at it in terms of the patients themselves rather than at hospital level, that gives us much more detail to work with, and just the scale of the data is much higher. So rather than 42 of these hospital regions, we're looking at thousands and thousands of patients. So that gives us a lot more precision and a lot more confidence in any patterns we tend to see. Likewise, we can ask, who are these patients, and see if there's anything that might explain it. Are they older or younger from certain ethnic groups? Is it led by sex or ability or disability? And likewise, we can look at their medical history, history of diseases, measurements taken, what medications they might be on, and hospital visits. And most importantly, we can get a clearer idea of the timeline, what happened before their scan, what happened after, how recently did it happen after, these kind of things. And that's the kind of strength of evidence we really need to be able to make changes based on this. So this is where Shield CVD comes back in. I've kind of set the scene there with what might be described as the problem or an example of the limitations if not using this. But what we'd love to do, and what we are doing, is using a Scottish medical imaging data set from a similar point in time. So what Jonathan was looking at was English data at hospital level, but the Scottish medical imaging set, similarly from the 2010s, allows us to look at millions of individuals at individual level. It covers the whole of Scotland, which is very representative. That's really helpful for us. And it includes tens of millions of imaging studies. So it's a very rich data set. And we also see these patterns in the data set. So I'm going to whiz through a few of the graphs of what we're currently seeing. This is very early results, so there won't be a lot to tease out just yet from it. But we do see these patterns of increasing or decreasing use among certain types of scans, certain machinery. We see variations in age for some of them and sex for others. So who is getting these scans? Definitely we're seeing some of that. And we also see patterns, or at least know that there's a lot of data before that period of time, before their scans, so we can understand people's medical history beforehand, and likewise afterwards. So the red window there is actually the window where the scans occurred, but we can look back and look forward as well to understand the context and the follow-up. Likewise, as the others mentioned, phenotyping, we can start to think about who has been diagnosed with certain conditions or diseases, and then start to build cohorts around that, particularly ones in close proximity to a particular scan. So if we come back to the barriers to research, we can see that this set is hugely important to being able to link to other health data and look into what the scan might have been used for and some of the earlier results, and to be able to access it. And on the topic of accessing, the data that sits behind these kind of scans is huge. So if you consider what might be more of a bread and butter data set for us health researchers, mortality data, People can only die once, so therefore there's very limited information per person. However, when you start to bring in hospital visits, A&E visits, you can see these graphs go up. Therefore, the size of these data sets go up. When you start to bring in imaging data and those supporting it, they go up a lot more. Now, it's not always obvious from this graph because it's logarithmic, but you'll see that, for example, the SMI series one at the end is about 20 times larger than the deaths one. And likewise, when you get into the medications data or the particular snapshot level of certain scans, it's huge. So this really would slow down a lot of research projects. And that's why I'm going to come back and talk about the aims of Shield CVD here at the end, which sounds a bit strange. But what we'd love to do with this is try and replicate Jonathan's work on English data, but on this patient level Scottish data, which is far richer, patient linked, and we can just rely on this evidence a bit more of whatever insights it might show us. But we also hope that this will be sort of like a path we're treading that a lot of other researchers can follow. So along the way, what we're doing is working hard with Public Health Scotland to streamline the applications process, so it's a lot easier for other researchers to access this data. That was one of the barriers. We're working hard to make sure our code and cohorts that we develop is readily available, so they don't have to reinvent the wheel, reclassify all these scans, figure out which patients got what. They can borrow a lot of what we've done or repurpose it. And likewise, what we'd love to do is create a community around this, so of researchers. And we've already started to do that, and there's been lots of positive interest from various workshops we've had before. So I'll wrap it up there and just say we're really excited about this project. It's already looking promising, and more exciting results to come in the next few months. But I would particularly like to thank those working on the team. So Michelle and Jonathan, who are cardiologists, Ross, who's our governance expert, Amy, Stephen, and co-workers at Public Health Scotland, who have been fantastic along the way. So very much team science here, and we're looking forward to being able to share more online soon.